The field medics whispered about Sarah's unusual technique and called her methods unorthodox. A woman who sutured wounds with surgical precision and administered medications in calculated doses seemed too advanced for a combat medic, but they didn't know where those skills came from or what they cost to acquire. Not yet. They thought she was just another overqualified medic until the medevac alarm screamed and 47 critical wounded needed saving in ways no field hospital had ever seen. Before we start this video, in which field do you feel more skilled than your colleagues? Share in the comments. Staff Sergeant Sarah Scalpel. Mitchell, 42 years old, dark blonde hair, always in a tight bun under her tactical helmet, green eyes constantly scanning everything. She's been working as a combat medic at Forward Operating Base Alpha's Field Hospital for 3 years. Wearing standard Army combat uniform, tactical boots on her feet, seemingly a typical field medic. But Sarah's hands surprise everyone. Surgical precision field surgery, perfect IV line placement, assessment triage in seconds. Most importantly, the old scars on her hands. Thin surgical scars, chemical burn marks, details that only experienced surgeons possess. Why does Sarah know such advanced procedures? Too sophisticated for a combat medic. She works like a trauma surgeon. Medic training isn't like this. Sarah has been hearing these whispers for 3 years. She never offers explanations because the real story is locked away in classified Pentagon files. That Friday morning, routine patrol preparations were being made at FOB Alpha. While the field hospital was quiet, Sarah was checking medical supply inventory, morphine stocks, surgical instruments, blood products, emergency medications. The other medics working beside her were talking about her. Sarah used that weird suturing technique again, said medic Jessica Rodriguez, like she's doing plastic surgery. I noticed too, medic Marcus Santos replied. Her chest tube insertion is like routine procedure. Senior medic Linda Thompson shook her head. She's been here 3 years, but still different from standard protocols. She does everything her own way. Show off, added young medic Kevin Park. Like we're basic medics and she's super advanced. Sarah heard these conversations but didn't react. She just focused on her equipment checklist because the real story was very different. Staff Sergeant Sarah Scalpel Mitchell was actually Lieutenant Colonel Sarah Mitchell, U.S. Army Medical Corps, who had served 15 years as a trauma surgery specialist. She'd been deployed 6 times to Afghanistan and Iraq, in Mobile Army Surgical Hospital, MASH units, in forward surgical teams under impossible conditions. She had saved thousands of lives, but 3 years ago she'd experienced a PTSD crisis, given up her rank, and re-enlisted as a combat medic. Quiet life, less responsibility, forgetting old traumas. At 9:23 that morning, everything changed. Emergency communication alarms began blaring throughout FOB Alpha. Code Red Mass Casualty Alert, the worst type of combat emergency. All personnel, mass casualty incoming, IED convoy hit, count 47 wounded, multiple urgent surgical, ETA, 12 minutes, all medical personnel to field hospital immediately. The base instantly went to combat readiness mode. Soldiers running, medics preparing equipment, personnel taking evacuation positions. Captain Robert Chen, Field Hospital Commander, called an immediate briefing. Large convoy, 3 Bradley fighting vehicles, 8 Humvees hit by coordinated IED attack, multiple blast injuries, fragment wounds, severe burns, crush trauma. The largest mass casualty since deployment began. Sarah automatically made tactical medical calculations. 47 wounded, 2 field surgeons, 6 medics, average 23 critical patients per surgeon. Impossible survival ratio. Triage protocol Bravo. Captain Chen continued. Immediate cases to surgical tent. Delayed cases to stabilization area. Expectant cases to... A different system was working in Sarah's mind. Advanced combat casualty care, damage control surgery, massive transfusion protocols. This field hospital was about to face a type of carnage it had never seen before. The first medevac helicopters landed 10 minutes later. Rotor wash, dust clouds, urgent shouts. Incoming! 22-year-old male. Blast injury to abdomen. Evisceration, shock protocol. 24-year-old female, multiple fragment wounds, possible internal bleeding. This way. 19-year-old, burns 40% body surface, airway compromise. Chaos began. Litters filled the field hospital, blood, screaming combat soldiers in agony. Standard field protocols were insufficient. Captain Chen was trying to coordinate but was overwhelmed. Who's going to surgical tent 1? What's the blood bank status? Are medevac rotations ready? Sarah looked at the first casualty. 26-year-old soldier, blast injury to chest and abdomen, multiple penetrating wounds, hemorrhagic shock, blood pressure 50/30, dying. Jessica, Sarah commanded, start O-negative blood on this casualty. 14-gauge IV bilateral massive transfusion protocol. Sarah, you're a medic. You can't make surgical decisions. Do it now. Sarah's voice carried officer command tone. This soldier will die in 8 minutes. Jessica hesitated, but Sarah's authority convinced her. IV access established. Blood products started. Second casualty, 20-year-old female, convoy gunner, blast injury to extremities, possible compartment syndrome. Marcus, Sarah directed, prepare fasciotomy tray, monitor compartment pressure. Sarah, this is Captain Chen's authority. Captain Chen is currently handling 8 different casualties. You will watch for compartment syndrome. Sarah moved to the third casualty. 28-year-old male, blast to face and neck, possible airway compromise, vascular injury. This assessment required Sarah's specialized knowledge. Maxillofacial trauma, carotid artery injury, surgical airway requirement, advanced trauma surgery territory. Kevin, Sarah called. Prepare emergency cricothyrotomy tray. Kevin was surprised. Sarah, you can't do surgical airway. You're a medic. I'll assist. When Captain Chen comes, I'll support. But Captain Chen was dealing with 12 different critical casualties. Sarah looked at the patient's vital signs. Oxygen saturation 70%, stridor present, cyanosis developing, imminent airway obstruction. This soldier will have respiratory arrest in 4 minutes, Sarah quietly assessed. Linda Thompson approached. Sarah, we must follow field protocols. Field protocols don't cover this situation, Sarah replied. Emergency airway needed. Sarah showed Kevin the cricothyrotomy procedure. Palpate cricothyroid membrane, vertical incision, horizontal entry, tube placement. Sarah, I can't do this. You'll assist. I'll guide. Sarah guided Kevin's hand. Skin incision, membrane penetration, tube insertion, emergency airway established. Immediately, the patient's oxygen saturation improved. 95%. Stridor resolved. Cyanosis cleared. Life-saving intervention. Kevin was shocked. Sarah, how do you know advanced procedures? Sarah didn't answer. She had moved to the 4th casualty. At that moment, Captain Chen came to Sarah's side. Mitchell, what did you do with this patient? Emergency cricothyrotomy, sir. Airway obstruction, surgical intervention performed. Captain Chen checked the vitals. Flawless technique. Who performed it? Team effort, sir. Captain Chen looked at Sarah suspiciously. Mitchell, what exactly is your background? Combat medic, sir. 3 years FOB experience. How do you know these advanced procedures? Sarah hesitated. Extensive field training, sir. At that moment, radio communication crackled. FOB Alpha additional wave incoming. 15 urgent surgical multiple amputations mass burn casualties. ETA 6 minutes. Mass burns traumatic amputations. Sarah's ultra-specialized area. Captain Chen panicked. 15 more casualties. Field hospital capacity exceeded. Sarah looked at Captain Chen. Sir, we need to implement advanced combat casualty care protocols. Damage control surgery approach. Mitchell, you're a medic. Sir, I can provide guidance. This situation is beyond standard field medicine. Captain Chen looked around desperately. His medical team overwhelmed. Resources critically low. Incoming casualties requiring impossible care. What do you recommend? Sarah's mental combat surgery protocols activated. Forward surgical team approach. Primary survey. Damage control surgery. Stabilization for evacuation. Stop bleeding. Restore circulation. Prevent infection. Damage control surgery. Life-saving procedures only. Detailed repair, later at higher echelon. Captain Chen realized Sarah was discussing advanced military surgery. Where did you learn this level of trauma surgery? Does it matter right now, sir? The second wave of 15 critical casualties arrived. Burn victims, amputations, massive hemorrhage cases. Sarah immediately took tactical command. Jessica, burns to isolation tent. Airway management priority. Marcus, amputations to surgical area. Hemorrhage control first. Kevin, shock cases to resuscitation bay. Sarah, Linda protested, you can't give orders to the medical team. Then Captain Chen give the orders. Sarah replied calmly, but this system saves lives. Captain Chen looked at the chaos around him, then at Sarah's organized, systematic approach. Do it, he decided. Mitchell's protocols. Sarah systematically triaged the 15 additional casualties. Her assessments, surgical level, rapid, life-saving accurate, 60% burn victim, immediate airway management, traumatic amputation, tourniquet, pressure dressing, rapid evacuation, multiple fragment wounds, damage control surgery, first critical case, 23-year-old male, 70% burns, suspected inhalation injury. Immediate intubation needed, Sarah assessed. Burn center evacuation priority 1. Major Williams, field surgeon, approached. Mitchell, how did you assess inhalation injury so precisely? Sarah pointed to the patient's symptoms. Singed nasal hair, carbon deposits around mouth, voice changes, stridor development. Classic inhalation injury progression. That's trauma surgery level assessment. Sarah didn't respond. She was already evaluating the next critical casualty. Second urgent case. 27-year-old female. Blast, amputation both legs. Massive hemorrhage. Sarah applied combat tourniquets, pressure dressings, established IV access for massive transfusion. Vascular surgery consultation, immediate evacuation required. Captain Chen watched Sarah work. Her movements, surgical precision, diagnostic skills, attending level, patient management expert beyond medic training. Mitchell, stop, he commanded. Sarah looked up from the 7th casualty assessment. Who are you really? Sarah paused. Around them, controlled combat medical chaos continued. Casualties being treated, soldiers crying, medics running between litters. Captain Chen, does it matter right now? Yes, it does. No medic has this level of trauma surgery expertise. Sarah looked at the suffering soldiers, overwhelmed medical team, life or death decisions every second. I'm Lieutenant Colonel Sarah Mitchell, U.S. Army Medical Corps. 15 years trauma surgery, 6 combat deployments, 4,847 lives saved under impossible field conditions. Silence. Even in the medical chaos, all staff within hearing stopped. Captain Chen stared. You're You're a trauma surgeon. Was. Now I'm a medic. Why? PTSD. Needed simpler responsibility, but today, simple isn't an option. Captain Chen hesitated for 2 seconds. Then, Colonel Mitchell, will you take medical command of this mass casualty event? Sarah looked around. 47 critical casualties, overwhelmed field hospital, life or death surgical decisions every minute. Yes, sir. All medical personnel, Captain Chen announced over field communication. Lieutenant Colonel Mitchell is now Medical Incident Commander. Her orders are direct orders. The transformation was immediate. Sarah switched from medic mode to trauma surgery command mode. Major Williams takes surgical Tent 1 abdominal cases. Captain Rodriguez, Tent 2 chest trauma. Lieutenant Park, Tent 3 burn casualties. I'll coordinate and handle complex multi-system trauma. But Colonel, Major Williams said, Field Hospital Authorization Protocols. Combat Medical Emergency Authority, Sarah replied. Life-saving operations override bureaucratic procedures. Sarah systematically organized the entire field hospital operation, patient flow optimized, resource allocation efficient, medical personnel assigned by expertise and capability. The next 8 hours were combat medical warfare. Sarah performed procedures she hadn't done since her surgery days. Forward surgical team techniques, damage control surgery, combat casualty care. Case 1, 21-year-old with massive abdominal trauma. Sarah performed emergency laparotomy, controlled hemorrhage, damage control surgery. Case 2, 19-year-old with traumatic brain injury. Sarah managed intracranial pressure, prevented secondary brain injury, stabilized for neurosurgery evacuation. Case 3, 25-year-old with multiple system trauma. Sarah coordinated multi-team approach, prioritized life-threatening injuries. By evening, the results were extraordinary. 47 casualties admitted, 45 survived, 2 KIA. Beyond medical intervention when they arrived. 96% survival rate in combat mass casualty event. FOB Alpha medical record. Captain Chen approached Sarah at 1800 hours. She was completing final medical documentation, still in blood-stained ACUS. Colonel, I need to understand. Why are you working as an enlisted medic? Sarah looked up, combat fatigue in her eyes. Because war broke something in me, Captain. I needed peace. The combat medic role gave me medical purpose without command stress. But today my past became necessary to save soldiers' lives. Colonel, I want to recommend you for Medical Corps reinstatement, full rank restoration. Sarah considered. Captain, I appreciate it, but I'm not ready for that command responsibility. Then, consulting surgeon, complex cases only? I'll consider it. Battalion command arrived at 1900 hours. Colonel, executive officer, medical liaison, mass casualty events required investigation. Captain Chen, battalion commander Colonel Harrison asked, explain how we achieved 96% survival rate in unprecedented mass casualty. Lieutenant Colonel Sarah Mitchell commanded medical operations. Lieutenant Colonel, we don't have field-grade medical officers assigned. She was working as a combat medic, former trauma surgery specialist. Silence. Command staff exchanged glances. Medical liaison, Major Patricia Hayes, spoke. We need a complete briefing. This survival rate defies field hospital capabilities. Sarah was called to the command tent, still in ACUS, still exhausted. Sergeant Mitchell, Colonel Harrison began, we need to understand what happened. 47 critical combat casualties arrived simultaneously. Standard field protocols insufficient. Advanced trauma surgery protocols implemented. Result: maximum soldier survival. But you're an enlisted medic. Today I was. This afternoon I was whatever these soldiers needed. Major Hayes leaned forward. Your techniques, they exceed field hospital capabilities. Combat trauma surgery saves lives under impossible circumstances. Today was impossible circumstances. Are you qualified for trauma surgery command? Sarah paused. Former qualification. Emergency medical authority allows appropriate intervention when soldiers' lives are at risk. Legal complexity. But results spoke louder than regulations. Colonel Harrison made his decision. Sergeant Mitchell, we're recommending you for direct commission restoration. The Medical Corps needs your expertise. I appreciate the consideration, sir, but I need time. Understood, but Sergeant, the Army needs surgeons with your capability. 2 weeks later, Stars and Stripes headline, Combat Medic Saves 45 Soldiers in FOB Chaos. The article didn't mention Sarah's officer background. OPSEC protected, but the medical community knew. Sarah returned to medic duties, but everything had changed. Personnel treated her differently, not because of rank, but because of respect earned through excellence under fire. Sarah, Jessica approached. Will you teach us advanced trauma techniques? Which ones? All of them. We want to learn combat surgery. Sarah started weekly training sessions. Advanced trauma surgery for field medics. Combat casualty care techniques, life-saving procedures from surgical experience. 6 months later, FOB Alpha had the lowest KIA rate in theater. Sarah's techniques had transformed the entire field medical capability. Captain Chen asked her again, Colonel, ready for Medical Corps restoration? Sarah looked at her hands. Scars from combat surgery, memories from impossible saves, skills that bridged enlisted and officer medical worlds. Not yet, Captain, but I'll keep teaching. Knowledge saves soldiers. And if another mass casualty occurs, Sarah smiled, then I'll be whatever these soldiers need me to be. Because some warriors never truly leave the operating table, they just find different ways to serve. Sarah Scalpel Mitchell, former Lieutenant Colonel trauma surgeon, current combat medic, eternal soldier healer. If you were in Sarah's position, what would you have done in that critical moment? Would you risk breaking the rules in such a crisis in your own field? Share your most challenging, I had to break the rules moment in the comments.